There are multiple agencies with different recommendations for when a patient should be screened for breast cancer. At Johns Hopkins, we follow the recommendations set by the American College of Radiology and the Society of Breast Imaging. The recommendations are for every woman who's of good health to have a mammogram once a year starting at the age of 40. Some of the misconceptions that we hear as breast imagers is when patients say, "Oh, I haven't hit 50 yet, I don't need a mammogram." What patients need to remember is that 1 out of every 6 new diagnoses is in a patient who's in the age range of 40 to 49. Also, patients sometimes say, "I don't need to get screening mammogram because I don't have a family history of breast cancer." What patients need to know is that about 75% of our new diagnoses do not have a family history of breast cancer. And the other misconception that we routinely hear is patients say, "Well, I'm tired of coming every year, I'm just going to come every other year." And the data has shown that changing from annual mammography to every other year can delay the diagnosis of breast cancers by about 30%. It's very important for patients to know their risk factors. We encourage patients to have this conversation with the referring clinician so that they know what their lifetime risk factor is. If you have any known genetic condition, such as a BRCA genetic mutation, or if you have a strong family history of breast cancer and certain other conditions that are concurrent, this may increase your lifetime risk of breast cancer. For these patients, we will recommend an annual mammogram as well as additional testing with a supplemental imaging technique called Breast MRI. It's very important for patients to know the risk factors so that they can get the appropriate surveillance for breast cancer. Fast breast MRI is a shorter version than the standard breast MRI. It is a scan time of less than 10 minutes. The fast breast MR is not new technology. It has been performed in other countries such as Germany and other academic institutions for years. It has been proven to find invasive breast cancers early. We couple the fast breast MR with the mammogram for patients who are at average lifetime risk of breast cancer, but may benefit from additional screening. These patients include patients with dense breast tissue. It's a good conversation to have with your referring clinician to see if the fast breast MR would be a nice supplement for a patient with dense breast tissue. I am very excited about a new development in breast imaging. It is AI. As we all know, AI is computer technologies that try to take the data sets and mimic what human intelligence can do. So at Johns Hopkins, we have implemented AI into our daily work when it comes to mammography. We have a software system that we work with, and the software system works as a second reader. So at all Johns Hopkins facilities, every mammogram that's performed, the radiologist reads it first, and after the radiologist, the AI reads it. Hopefully the radiologist and AI agree. If they don't, we consult with a second radiologist who works as a tiebreaker. And I'm proud to say that at Johns Hopkins, we do not charge the patient for the AI. We offer it for every patient that has a mammogram at all of our facilities. What is unique about Johns Hopkins Breast Imaging is that we are not a standalone imaging facility. All our imaging facilities are in a coordinated, comprehensive approach to breast cancer. We work closely with the breast surgeons that are Johns Hopkins breast surgeons, with pathologists who are Johns Hopkins breast pathologists, radiation oncologists, medical oncologists, and a whole ancillary team which includes support services. So if a patient does have a biopsy and does have a breast cancer, we are there to help with every step of the way.